Hello, everyone. I'm Bridger Meekum. I'm going to give everyone a couple minutes, maybe 2 minutes to log on here. Actually, you know what? Should we just start on time? What do you think, Laura? You're pretty punctual.
Let's do it.
Let's go. Okay. So yes, to begin, I oversee the marketing side of things at CareXM. I am honored today to introduce the topic as well as our speakers, which I'll get into a little bit later. First and foremost, though, I wanted to thank all of our RNs out there. It's Nurse Appreciation Week. We all should show our appreciation each and every day, each and every moment. Especially, now more than ever, we're asking more from our nurses than ever before, to be on call, to then take a shift, and we need to do better for them. But thank you to every RN out there, every nurse out there, regardless of the field, for the care that you provide, the love that you provide to each one of our families and loved ones, and eventually ourselves. So also want to thank the audience for whomever's joining, as well as who will watch this at a later date. We appreciate the time and energy, and I say this often, banding together to try and change things. We need change in hospice, we need change in home health, and we need to drive our government leaders really for that change as well, to support these industries more, and to really transform what end-of-life care looks like, not only for patients and their loved ones, but for the clinician as well, and the organization overall. So today what we'll be discussing is the hospice RN experience from 4 RNs, the hospice space, each with different backgrounds, different experiences that they can share and perspectives, which will be fun to hear. And through that, we'll discuss really, the heart of every interaction is that patient and clinician experience. It's what drives the experience overall, and how you're eventually going to get rated as an overall organization. So we're going to talk through some common challenges clinicians face in hospice, what we can do better to address the clinician staffing crisis, as well as solutions to improve. With the game has changed. It's not the same as it was 5-10 years ago. The staffing gap is only widening, and our margins are getting more and more constricted. And so, I think it was Einstein that said doing the same thing and expecting a different result is the definition of insanity. So let's not be insane, let's be innovative. With that, I'm going to introduce each one of our speakers today, and very excited to have each one of them on. First, let me pull up. I don't have their exact bios memorized as much as I can, talk through each one. Christy Fisher, very early in her education, Christy felt a kinship to healthcare, and in 2001 earned her BSN from the University of Utah. She then worked for 2 years in oncology, being especially drawn to caring for patients whose lives were coming to a close. In 2003, she made the transition to hospice, where she's been helping patients and their families ever since. Working for several years as an on-site hospice nurse, Christy has found an even more meaningful niche, providing telephone triage for hospice patients, where she's helped guide patients and caregivers through especially urgent and emotional situations. Thank you, Christy, for joining us today. Next is Laura Dyer. As a pre-med student at UCLA, Laura studied physiology and planned to attend medical school to pursue her passion for creating outstanding patient experiences. In her final year, however, she decided to change course after identifying the role where she could have the greatest impact on the patient experience was not as a physician, but as a nurse instead. After UCLA, Laura continued her education at Johns Hopkins School of Nursing and an accelerated BSN MSN program. Thank you as well, Laura, for joining. I'm going to call on her and pick on her today. Also here is Heather Armstrong. And there's a fun fact that I'll share with you about Heather that I just learned. She's the clinical experience supervisor at CareXM. As such, she mentors and trains incoming triage nurses. Her unique background as a body healer helps inform her nursing and nursing instruction. She's the former director of clinical services of Lake County, California, an RN case manager for home health organization right at home in Santa Rosa, and the lead spa therapist for a famed Bardasan spa in Napa Valley. Man, she's got some cool stuff. She also was a former Olympian in bobsledding, which is pretty fantastic, much cooler than I am. Thank you, Heather, for joining us. And last but not least, Christine Rodriguez. She will be joining us a little bit later. She's actually taking care of her team and had to hop off to help her care team. But Christine has spent many years working as a home health, private home care, and hospice admin, doing building billable hours, increasing census by 50% or more, recruiting and retaining high quality staff, and piloting and training staff to new EMRs. Her work in communities of El Paso and Augusta have opened her eyes to the racial and ethnic disparities that exist in the US today for healthcare. And just overall, she is passionate about helping these families and all families navigate and understand the world of hospice, home health, and beyond. So thank you so much, all four of you, and I'll thank Christine later for joining. And then we'll get rolling here if that works. So with that, I'm going to pose the first question. So in your guys' opinion, unique perspectives, what are some common challenges clinicians have faced, especially in hospice?
Wow, that's a loaded question. We could probably take the whole time to talk about that, but I think first and foremost, when I was director of nursing for hospice, and even with what I do today, it's all about the burnout. It's all about the on-call time, the time you have to serve 24/7. These patients don't keep to a daytime schedule. You know, they have needs that are holidays, weekends, all that time. So it's definitely that burnout and trying to coverage, whether you're a small service that has just a handful of nurses that have to leverage out between the whole week, or you're a larger group that maybe has the luxury of having a triage team, but you still have nurses that have to be woken up and they still have to make the visits. So I would think hands down, it's the burnout.
Yeah. Anything to add there, Heather or Laura?
I think too, with hospice in particular, the at-home care model is something that is definitely more needed these days, but it's accelerated faster than really the industry has been able to provide solutions to support it. So there's this desperate need to find efficiencies in this workflow and provide a better experience for nurses. I think the pandemic accelerated that for sure, but the technology and the software and the ability to actually change process hasn't really followed that accelerated path that we've seen to really need more support in the at-home care environment, whether it's hospice or home health or hospital at home, like all these new things that are evolving. Hospice was kind of one of the first to really set the stage, hospice and home health, to really present that opportunity that patients can be cared for at home. And now more than ever, we need it. And really, we need solutions that can help them provide that care experience at home more effectively.
And I think if you add to that, the transition, something that I've seen throughout my career is the growth of the palliative care environment that goes right into between those home health and hospice. And I've loved seeing that it's just taken force, and that there's now palliative care teams in the hospital, but there's also a big focus on the community-based palliative care, or whether it's a CCM program or RPM, or all those different things that touch that hospital at home. But I think the palliative care model that links with hospice is really cool, because we're addressing those needs that maybe they're not quite eligible for hospice, but we still are giving the care. And it obviously it's got several return on investments with the patient experience, but also the financial improvements and things like that, that keeping patients out of the ERs and all those different things. And On the flip side, though, there are some challenges with that. There's the challenges of, how do you afford to embark in both of those spaces, and how do you meet the needs of the differing patient models, and asking your nurses to do both. And, sometimes you have those hard decisions of whether you can accommodate both. You can see different clients and companies that have a model where they can sustain both home health and hospice, or sometimes they get to a point where they have to choose one or the other because of staffing resources or financial models. But I definitely think that the concepts are there and they're growing and evolving, which is awesome. But there's definitely some challenges for hospices to expand a little bit and incorporate these things into their model, especially with their ever-growing, I should say decreasing budgets and reimbursements and things like that. So hopefully, as we talk about some of the catch-up that needs to be done, as Laura mentioned, we know the work that needs to be done, but there's a catch-up to reimburse and get the dollars to finance and really fine-tune processes to make the efficiencies and make it all work together.
And I feel like another challenge that we do have in hospice is educating the nurses, especially someone that's new to hospice, a nurse that's just coming in, using that technology and all the other resources that are available to provide a meaningful education to those nurses, to increase their education that they've got, as well as educating all the new nurses that are coming in. So fortunately, we do have technology coming in that does help with that education piece, but we want to close that gap, that knowledge-based gap, and provide better patient outcomes and better education for families going through the whole experience as well.
Yeah, I think that's a big call out. Being Nurses Week, we had an internal thread going where there was a post about people posting pictures of themselves as they graduated nursing school. And it made me feel a little bit old being over 20 years in the nursing field, but it actually was a good thought to remember how much has changed in both the hands-on care of patients as far as technology goes, but also the training, as Heather mentioned. I remember email was a newer concept when I was in nursing school, and now email is so simple and obvious, but it's sometimes working different apps or programs that your nurses who are fabulous bedside nurses, but maybe they struggle with keeping up with the apps that really could help their timeliness, or charting in the EMRs and pulling all those pieces together. Those are definitely challenges to mesh these worlds that have come so fast and so far in such a short amount of time.
It's great. No, and I agree. I mean, I haven't been in the field, but I mean, there'd be nothing more frustrating than not getting the proper education, but still having the intent there to provide the best care possible. So that's great. Okay.
Richard, can I?
Oh, go ahead.
Yeah, I was going to throw one thing out there. One thing that Christy just said that kind of threw off some alarm bells, like this need to solution is so rampant, and it's necessary, but it's now creating additional problems because now we have so many solutions and there's an app for everything. And as nurses, one thing that we see in our unique space is that we see clients that they have too many apps. And, what's one more app? And now they have to remember to go here to do one thing and there to do another thing. And we're trying to solution so many things, and there's great intentions, but it's now causing new problems. And I know that I hear this from a lot of the different agencies that we work with, that is a big problem, that they really don't want to introduce new applications to their teams because it's this burnout from technology, and really trying to help support them and seeing the value of these applications. But how do you introduce it without having one more thing that they have to remember to log into, and one more thing that they have to remember to go and chart in or add a note there? It's a very complicated web of things.
Yeah, we're definitely needing to focus on simplifying and streamlining so you're not in 10 different areas even though they're all well-intentioned.
Right. Right.
Makes sense. Yeah, the technology should augment the, the human side of care and make sure that you guys have more efficiencies in the workflows that you utilize versus what's my login again for this.
Yeah. And a rule of thumb that I go by when I'm looking at different technologies is this going to help me give more time to the patient and to the patient experience in that care? Or is this going to just serve as another check mark that's another layer that my nurses have to train and learn on? I think that's a good rule of thumb. You always will have training, but is the ROI going to increase the patient's experience? And if so, then it's probably worth looking at. If it's something just to check another checkbox that's not going to impact patient care in a positive way, or not going to impact the nurses in a positive experience after that change management's been done, then that's something to think about.
That's great. Okay, I mean, we've hit on the challenges. Are you guys ready to talk about some what we can do better for the staffing crisis? Can we start there? Okay, so what can we do better to address this crisis, especially as the gap is widening?
Gosh, for me, because I have a lot of nurses that report up through me, the biggest thing is we need to listen. We really need to find ways that we can hear what our nurses are dealing with and what their day-to-days are doing. It's hard, especially in the hospice world, to go make hands-on visits and to do a day in the life of each nurse, because the different areas are so diverse. With, you may be in rural, you may be in an inner city, you may have lots of various challenges, but I think you need to get to know your nurses and know what's going on and listen. And that sounds a little cliche, but then the next step that is often missed is, once you've listened to that, it might be that emotional feeling that they're having, peeling back the onion to say, why are they facing this burnout with so many visits in a day? Is there something that could help us to better align our case managers with what visits they're making? Or is there data that backs up that I can take to my leadership to say, hey, we're burning these people out because they are making this many visits, they're having this many miles, and we have the data that shows what they're actually doing. A lot of times it's just they're out there doing their visits, and we know that if their charting's done, they're out there, but we don't always have the insight as to what are they actually doing moment to moment during their day, like we would in a hospital setting.
And I think the fact that when the nurses are out on a visit, the multitasking that now is coming along with it, if they are on call and they're the only nurse out there, they could be, really spending time with family, say if it's a death visit, and then the phone rings because they're on call and they have to answer and triage a call. It takes away from the patient experience, the family experience, but also is very stressful for the nurses. So how do we address, taking some of that burden off the nurse to when they get those additional, tasks or calls that are coming in, to multitask a bit and just be able to focus.
We talked about that a little bit, a little bit, Heather, as well, just how much it does hurt that experience, and then also trying to manage, some of the compliance requirements and whatnot, and what you have going on. And, again, the intent's there, but, between being, short-staffed and asking more, not having that education piece, I mean, that seems to build training chaos, right?
Well, and something that we actually have done in my world, we do have an application that my team uses, and the cool thing and the reason why it came to be is because I needed a way to support my clients and to know what they were up to. So we built an application that essentially the nurses that were on call, I'm the triage nurse, and if I knew that they were at a visit and I knew they were at a death visit, then I knew not to call them, but I didn't know how long they were there. I didn't know if the family was in crisis. So we built an app that basically said, I'm the nurse on call. So I had an app that tells me who's on call, and I can see everybody on call, but it also shares with me what they're doing. If they're available in a green state, what we call it, then I can call them because they're not with a patient. But if they're with a patient at a death visit, or they're in an admission or something like that, or even if they're headed out to a patient in a rural community, they can put their status as being unavailable. And I, as the triage nurse, know they're out of commission for a while. And so I need to either go to a backup or find ways to help the patient over the phone until they're available to go and make a visit if that's what needed. So that's one way that in my world we've helped solve for that. I'm lucky enough that I have a platform where my app connects to my documentation portal. And so I can see it all in one spot. So I don't have multiple places logging in, but that's been a real value for my team as I'm working with our clients to be able to have that status availability.
I couldn't get off mute fast enough. Christy beat me to the punch. So thank you, Christy. But aside from the app that she just described, I think that what we've seen, and Christy, I know you've mentioned this in conversations we've had, we see the hospice industry, there's like this wave, this pattern that we see happen where the problem that agencies face is nurse burnout. And they come to realize that they have to solve for that. Like that's their wound, what they need to focus on and solve first when they're triaging their own internal operation. So they focus on the nurse burnout. And then once they've solved for that, whether it's using software, whether it's using a service, we see that they end up finding a new problem that then puts them right back into that position where the nurses are burnt out again. It's typically the balance between the nurse burnout and cost savings. It's really hard to find that balance between the two. When with call center triage that we do within our organization, something that a lot of us were not familiar with, not really understanding. We first started this path 12 years ago, really understanding what it meant to staff a call center and understand call volume and how you staff nurses to handle those calls. It's really hard to staff when you have a very small pool of people to pull from. And so when you have one nurse, like Heather was describing, and you have one nurse that's making the visits and taking the calls, something is going to have to give. You're either going to have the patient that you're visiting is not going to have the best experience, or the nurse who's making the visit is going to be frustrated because they have to take the call, or it's the patient that tried to call in or the caregiver that has to wait or goes to voicemail. Then you try to relieve that burden, you might add more staffing resources. And then what happens when you don't get the calls and you don't have the visits? Then you have more than enough nurses that are sitting around. And it's really hard to find that balance. And so along the lines of what Christy said, it's trying to find a hybrid model. How can you provide that service experience for the patient that you're visiting, for the patient that needs the visit, that's next on the list, for the nurse, and really provide it all at the same time. And so what we have done with our organization, what we found is it's a sweet spot essentially of how do we send calls to nurses when they are available. And then if they're not, because they're at a patient's house, making a patient visit, that the app can then identify their status and send that call elsewhere. So the patient gets the focus that they need while the nurse is there at the visit. The nurse gets that reassurance that the patient that needs to get seen, that needs that help, maybe just education over the phone, that there is another nurse available that can take that call. So they aren't the only ones there that can help that patient and support that patient. It was a process, to say the least, to really figure out how we could make that work. And not saying that it's perfect, but it definitely has helped to find that in between, that model where you can have the best of both worlds in a sense. I don't know, Christy, if you have any thoughts on that.
Yeah, no, for sure. It definitely has been even a paradigm shift on our end, where we wanted to be helpful in helping clients triage, but we realized the value of utilizing their internal staff is the primary. They know the patients the best. So giving them that opportunity to make that connection when they're available, but decreasing the stress or the burnout on the nurse when she's with the patient, so she knows that when she's focused on the patient, that call's not going to go to a voicemail. It's not going to go to, somebody that all they can do is take the name and say someone will call you back. It's going to go to another nurse that has information about them, that can talk them through what's going on. They can do that initial triage over the phone and answer a lot of questions and give them guidance on maybe what medications they could take, or educate them on what's happening with a loved one if they're entering into an active dying process until that nurse can become available. We've found that it's decreased hospitalizations or those ER visits where patients don't get a timely response or answer. And so they panic and they call an ambulance, or they take them to the hospital because, I couldn't get through. So that's been one of the most rewarding parts of living through this transition, is just finding ways to empower the on-call staff, but still giving them that backup reassurance. And then you kind of switch hats to more of the administrative model when you're looking at financial impacts. And if you can utilize your staff, that you have a salaried on-call person, you want to utilize them as much as possible, but you don't have quite enough bandwidth to do 2 of them. So you do that hybrid model where they take as much as you can, and then you have somebody that just is a backup that can give you like half an FTE or something like that, spread through whatever hours is needed. So it gives a lot of flexibility that way, and that's something that's been really fun to build and support our clients with, because it definitely wasn't where we started with just 100% send us all your call volume type of answer. We're really wanting to help clients be the best for their patients, because it's all about the patient experience.
Love that. So we're going through, I guess, our own elements in the industry. We've talked about training and education, multitasking, and asking too much. I mean, multitasking is really impossible. Your brain can't. And the last one with the intent of technology helping, but really causing us a lot of angst that goes back into training. Now we have to get trained on a new platform that doesn't really tie into another one. Does that summarize those 3 symptoms well? Did I graduate that in your clinical opinion? Any other elements that you can think of? I mean, think of leaders in the space, business leaders as well, admins, any other things that come to mind?
One thing that Christy alluded to earlier has to do with data analytics, some way to get insights into your practice, like what's going on right now, where are those inefficiencies, and not only identifying them, but then working to find a solution for those gaps or inefficiencies. That is something that it's been a journey, but through some of the data collection that we do, just as a side effect of some of the documentation and the way that we track the work that we perform for triage, it's definitely opened our eyes to a lot of patterns and things that we didn't really recognize. For example, seeing a trend in how many calls on average we get after hours for hospice versus home health. Something as simple as that. I'm sure that people had ideas of, well, there's likely going to be more calls from hospice patients after hours than home health. But it was really interesting to actually get some numbers and really see that, yes, it is quite a bit more common, but then how many calls? And what does that actually mean for an agency? If they get 1 call per patient per week on average, is that good? Is that bad? Is it a sign of something else? Some of those questions, at least for me, because I'm constantly asking questions about, how we can improve process, how we can improve patient experience, nurse experience. So all these little pieces of data are really helpful for me, and we're now trying to educate our clients on what the value is of these data points that we can capture and how they can inform us of some of these patterns that we see and potentially how to make changes to improve. For example, one of the things that we track is, and this is necessary for hospice, is the primary reason why the patient's calling in after hours or why the family member's calling in. What's the issue that the patient needs help with? And we'll track that. And it's a call code or a call reason, why they've called in. And we've started to see trends or things that we would consider a preventable call code, a preventable reason for after hours calls. You can never prevent every single call, especially in hospice. That's why we have nurses on 24/7. But there might be certain things like medication refills or supply needs or DME, something's wrong with my oxygen concentrator. Those types of things, they might be more preventable. If you can actually see those numbers and see, oh, we're getting a lot of calls after hours for medication refills, maybe there's something we can do differently, a process that we can create and then employ so that our nurses, maybe the case manager, can check in at the end of the day or regularly so the patient doesn't run out of meds. So they don't need to call in after hours. Some of those things so that it leaves the nurse available for those more urgent needs that they really do need to be available to make a visit. That's something that we've really honed in on and we're really trying to explore more and understand more, is that data component and how we can learn from that and then help our clients learn to make those changes to improve their process, which then hopefully will improve the patient experience.
Yeah, that just reminded me of a recent client that I was talking with, and using those same codes, what they were able to do is they actually were looking at their pain crisis data. So looking at all the numbers of pain calls that were coming in and working with their team. So if we have any quality, QAPI people on here, they use this as a tool to gauge their outcomes. And they said, this is our baseline for how many on average calls we get related to pain issues. And then they did some interventions with teaching their case managers and asking their case managers to then teach and train their patients to be more proactive and being more competent and not only identifying early indicators of pain, but then also what to do when it comes on to avoid the pain crisis. And they're really seeing an increase in a decrease in calls, but an increase in that education. And they're using this tool to just track their after hours calls as their outcome measure. So it's really fun to see some of that because the data is awesome and it's great for those QAPI people. But in my mind, you think about the patients who are empowered to have a better experience and can identify and prevent any pain or suffering. So that's been a really interesting exercise that this client has gone through that I was learning about. But lots of things we can do with those call codes and just identifying what's going on.
Yeah, I've had an experience with a client who had quite a few calls for falls after hours, and they went through and reviewed the data and found out that all the calls were coming from one particular facility, and they took it on themselves to do an in-service for this facility on fall prevention, and they actually found that their fall calls went down. So using the data for not only educating patients and staff, but facilities and clients as well. So really exciting stuff.
Yeah, you can also look at it from a scorecard for your nurse managers too. You can identify nurse managers sometimes that maybe could do a little bit better with their med refill and checking in on those. If you have a high number of after hours calls that are, belong to a certain case manager or things like that, you can identify trends that way where you can gauge some of those knowledge gaps or management coaching opportunities.
That's great. Well, with this, I mean, this is your microphone. Is there anything else that we can do better for clinicians in this space? I mean, I think those are 4 great points. The insights from data are really solving the root cause for a lot of people's concerns, and no one really wants to be on a phone call for the most part, especially calling for a script or whatnot. But any other ones before we kind of dive into kind of some low-hanging fruit items with solutions, and we'll excuse you guys get back to your busy day.
I just wanted to add a little piece more to the management, sorry you have to hear from me. Because I manage a lot of nurses and been in that space before, to make it more of a positive spin, kind of going back to the nurse manager scorecard. I think it's actually really beneficial to give good data to the nurse managers so they can rate how they're doing themselves. Sometimes knowing when enough is enough, or knowing if I'm doing enough or not doing enough, is really helpful. You've got the people that are the nurses that are, they don't have any boundaries, and they don't know when to stop, and they don't know when to put their phone away, and then they get burned out, and then it's almost too late, kind of thing. But if you have some data that's like, you're making this many visits, or you're, if you're the on-call nurse, that kind of thing, this is where we think that you should be, and kind of having KPIs in the after hours so that they know what is expected. Half the time being on call, it's the fear of missing a phone call because you slept through it, or it's I'm getting so many back-to-back calls that this is way too much. So if we have data behind that can not only help the person who's working that shift, but also the managers to concretely see what's going on, it helps to put numbers so that it takes the emotions out of it, and to reframe that. It's a lot easier to say, I need you to be on call, and, we'll let you do up to 10 shifts or 10 visits per 12-hour shift, or whatever it may be. And then we'll get you some backup. Or if you reach this amount, that sort of thing. Or if you look historically and say, this is how many on average they're doing, so that you can kind of prepare them mentally. Nothing's worse than thinking, oh, I just need a quiet night. And then it just is a full moon, and then you have 12 visits, and those nights will happen. They will. But if you can walk through and look at the patterns historically and see that is clearly an outlier, because you have the data and it's easy to pull it up and see it, versus having to go and look through call logs and manually update and create those. I think that can be really beneficial for managers to make decisions based on how many is enough, what's not enough, how much call volume is coming in, how many visits are being made, and to staff it to the right level.
Love that. Because it gives the definition of what success looks like, not only for the manager, but can also come down as an organization and help, to your point. People can be their own worst enemy in terms of overcommitting, but especially in the care side, you're trying to, if you don't know what the expectation set is, you just keep putting more effort in, and then we're seeing that burnout happen. I love that, because that can give us good benchmarks as what a healthy organization and what a healthy nurse with a work-life balance, in quotes. It's hard to get work-life balance in this space overall, but that could help drive us to that. I love that, Christy.
Well, and then you can also take it a step further and do some sort of incentive or recognition where it's, so-and-so met their 100th patient visit on call, and they get a Starbucks card, or, something like that, where you're recognizing them for the efforts that they're putting in. And, things like that can be kind of fun to play with, to get some of that employee recognition, or, little kickbacks to know that they're being seen, especially if it's, oh my goodness, she holds the record for the most visits on a 12-hour shift. She gets the full moon award, but that includes I don't know, somebody that gets to cover visits for half the day or something. But you can make it fun like that, so that it's at least recognizing, but makes it easy to track and benchmark for sure.
So our management and exec teams can show care to our clinicians as well. I love that.
Yeah, and be aware. They don't know how it is until they see the data.
Okay, and glad I asked the question, because that was great, Christy. Anything else you guys can add, or should we go into? We've covered some of the solutions already. We could briefly touch on some outcomes and give you back your days if that works. Laura just messaged me and said she wants the full moon award, Christy. No, but in terms of outcomes,
that was a really good idea, actually. I liked that. The idea,
I think that's
gamifying
great.
it in a sense.
Yeah, gamify it, make it fun.
Definitely.
I mean, that's
Yeah.
honestly, let's make it fun again too and enjoy it. But if you guys can briefly share just some outcomes that you've seen, I'm sure the audience would like I mean, we've given them a lot. If there's like one or two low-hanging fruit items that they could leave with, that they could at least start to think through. If you wouldn't mind sharing that, that'd be great.
Well, I'm always an advocate for nurse safety, and Christy touched on nurses being out in rural areas, sometimes without cell service. And when I was a director, we were in a very rural area, many areas without cell service. So using some of these technology solutions, the apps that we use in particular did have tracking devices that told the administrators where those nurses were, if they were too long at a visit, are they okay? Are they broken down on the road? Have they been on the road for hours and don't have cell service? So using the technology for nurse safety as well, I think is a solution that can be provided.
Yeah, that reminded me of one of our clients that actually used our app when they had wildfires in their area and they had to evacuate. They actually used the app as a way to keep tabs on their staff to make sure that everybody was okay. And a very, very unique situation, of course, not something that happens regularly that you'd want to see happen, but it was, I remember them being so grateful that they had this piece of technology that allowed them to stay connected with one another. Safety is definitely something that you don't really think about it until you need it. And when you need it and you don't have it, it's too late. I know we've had a lot of clients that have, Heather, to kind of your point, something, knowing where they're at, it might not be as reassuring for the nurse if you think, oh, well, they're always watching me. They always know where I am. But if you're ever in a situation where you're in a patient's home and it's an unsafe situation, you'd be grateful that they know where you are. And if there's a way to then signal them or signal an administrator that I'm in an unsafe situation, I need help. Those are the types of things that you don't necessarily think about until you need it. I know we've actually had a lot of clients that have asked us about that and leveraging some of the technology to support those types of things with, because it is becoming there is an increase in nurse safety concerns, because there have been more reports of nurses running into unsafe situations in patients' homes. So it's definitely something that I think is growing, that isn't maybe as discussed, that does need some more attention and more solutions to it.
I think the one thing that we haven't really talked about that, nobody wants to talk about COVID again, but one thing that's actually been helpful, especially through the pandemic that we, obviously didn't predict, but we had been working on a solution for clients that are in areas with hurricanes like Florida or the wildfires or places where natural disasters or ice storms even, and they needed a solution so that if they couldn't open up the office, they could still have their patients get access. And so part of our technology allows you to basically take your phone system on the go and have calls forward to these nurses that are available. And so in times of emergency, you don't need to have the office open. The calls you just log into the app from wherever you're at, and then you can start having the phones forward to those people. And I know that's been a big success in hurricane situations or wildfires or any situation where up in the Northwest where there was a lot of ice storms previous years and things like that. But then certainly when COVID hit and lots of offices were shutting down, we couldn't shut down hospice and home health. We still needed some of those things, but it created a safer environment during the pandemic to do that. So it can be applied to all different things, but that's something to maybe think about with your disaster plans. Do you have a way to still get calls to your triage team or to your case managers in the event that somebody can't go to the office, things like that. And just considering that.
And I think to that point too, or along those lines, it's not just that you can route the call to somebody or know that somebody's available to take the call, but also feeling connected enough and having visibility, that you can see that the calls are being handled, that you can see that the patient's needs are being met. It's one thing to know that you have a system set up and that, yeah, in the event of an emergency, it's supposed to do this, but do you have a way to actually see that in the moment and keep an eye on it, essentially? Because when you're feeling disconnected, the last thing you want to do is not be able to see what's going on. And that was something, to Christy's point, early in the pandemic when offices were shutting down, but the care still needed to be provided. It was a necessity to have that interconnectedness and know in real time, okay, this patient called in and this person is following up with this patient, where normally you'd be in the office and be able to talk through it or have some other form of a call log or a shift handoff to communicate those patient needs. That was something that we definitely saw, an increase in that need to have that real-time visibility from a remote standpoint to see and verify that patient care was being met.
Well, I mean, that's great, because the routing to me is important, just because it addresses the multitasking issue. You know, if you're with a patient, you can set your status. And to your point, Heather, you have the tracking there too, to where you're making sure that your visit nurses are safe and you can be in contact with them, and we can actually give our freaking nurses a break here when they're not supposed to be on call or just be with their families. So that's great. Okay. Anything else to share before we, there's 2 or 3 questions here. Nothing? Okay, good. I mean, I love this hospice elements. I mean, that's what we need to fix. Let's fix those 5, 6 elements there. Or I guess it's 5. They all kind of tie together too. So real quick, one question: our timeliness of care isn't the greatest. Can you help with that metric?
Did you say the timeliness of care?
Timeliness of care.
Yeah, I can take that one. So we actually have had a couple clients that have been looking at this. They set a goal where they wanted to be within the patient's walls if there was a need for a visit within an hour, but they didn't really have a good way to track it, other than they knew maybe when the patient called in and that sort of thing, but they didn't really have visibility to what was going on. With our system, we showed them that we not only have the call that shows that it came in, we also have call recordings. So there's a timestamp associated with that. And then you can track from when the nurse changes their status on their app to say, I'm at the patient home or I'm at a visit, and you can see the distance between that. So just the visibility with the data to then kind of see what's going on. But then to take it a step further, what they did is they used a geolocation. So they were a fairly large client, and so they had several nurses, and they were able to provide the triage team with their locations via the app, which is the setting they turned on. And then the triage nurse, once they determined a visit was needed, they could look at their options of on-call nurses and see who was closest in proximity to the patient, and have a better coordination method of assigning out visits so that they could get a faster response to the patient and meet their goal of getting in the patient walls within that 1 hour's time frame.
I think too, one other way of looking at timeliness to care, and there's probably different ways that you could respond to the question, is, what is the patient or the caregiver's need? If the visit is what is needed, then, what Christy just explained is one way of measuring that. Because I think part of the dilemma too is you set this goal or you have this problem you need to solve, but then how do you measure it to know you've actually solved it? So having those metrics and being able to measure it is definitely a piece of the puzzle. But from a timeliness of care perspective, you could also think of just addressing the patient's needs or the caregiver's needs. If the caregiver needs education and they need education from a nurse, and you're using a non-clinical answering service, for example, and then the non-clinical answering service takes a message and then has to wait for the nurse to call back, and then the nurse has to call the patient back, it could be upwards of 30 minutes before the patient or the caregiver gets that answer to the question that they had. Having a nurse that can take the call on that first ring or the first that first connection can get the answer to the patient's question in maybe 30 seconds versus 30 minutes. So there's also that angle that you could look at from a timeliness of care perspective, which yes, we can help solution that and provide a solution option there as well.
Yeah, that was a good thought. I hadn't thought of it that way.
Okay, last question. Let's see. Can you help us build our data set? Like, it looks like they're having issues with that. I know
Yes.
we've run into that before, but can you help them build a data set?
Is that my question, Christy?
Sure, I'll let you answer it since I know you love the data.
I do love the data. Yes, I guess the short answer is yes. It's also dependent on, you know, the data set that you're looking at, the type of data you're wanting to track. There's so many different ways that you can really analyze providing hospice care, whether it's the triage, you know, telephone triage, that support, whether it's the visit support, whether it's you know, understanding the reasons for calling and really organizing it. First is understanding like what data it is that you're wanting to organize and define, and then really setting that standard. We internally with our organization, we do track a number of different data sets, which has grown over the years. And it's again been like a side effect as we create our process, we see this data as a result, and it's allowed us to really improve our process. So we have unique data sets that we are now trying to share with our clients and share what we've learned about this data that we're capturing, whether it's contact center, call volume, and staffing matrices that, you know, nurses would never have thought they'd ever, you know, in nursing school, never thought that I would ever know anything about that, or how calls route in an ACD call center, you know, things like that, that as we start to see this evolution in hospice and an interest, this growing interest in how to be more effective, how to be a better provider, how to provide better care, a better patient care experience, we see people now exploring other opportunities and other solutions that they hadn't previously. And it's opened a lot of doors for us. You know, we used to be a very niche nursing specialty is what I would really call it. A triage nurse is a specialty in a sense, providing care over the phone. And now we're seeing more interest and more growth in this space. And it's been fun for us to be able to share what we've learned over the last 12 years with agencies as they're just starting into this new world, to help them be as effective as they possibly can without hopefully making all the same mistakes that we did as we first started out. And we're really trying to understand this landscape because it is very unique, at least this part of the hospice experience, because you have to support calls after hours, whether it's your own team providing that support or a third party, it has to be offered. And so really, what's the best model and how do you optimize that for your own patient experience and for your nurse experience? All of those details and the data that comes along with that is something that was new to us, and it's really been fun for us to share with our clients and educate them about the importance of it.
Beautiful. Okay, I think with that, unless you guys have anything else to add, thanks again for all of your time today. Thanks to the audience, and again, special thanks to all of our nurses out there, and happy Nurse Appreciation Week to each of you.